I call upon the next speaker, Dr. Byanjana Vaishyal. What is your membership number, ma'am?
Actually, I don't remember.
You don't remember?
The number actually. It's
Every
20.
speaker must know the membership so that we can tell you.
20,000.
Anyway, please start your presentation. नहीं सब competitive session में है ये like one of the parameter.
Ratified or not? पेन नहीं है होता ही रहता है.
Good afternoon, everyone. Thank you, IOC, for giving me this opportunity. Today, I would like to discuss on innovative strategies for managing large corneal perforations in the absence of donor corneal tissue. No financial interest.
हाँ वही तो कर रहा हूँ.
As we all know, corneal perforation is an ophthalmic emergencies, and smaller ones can be managed effectively using cyanoacrylate glue, whereas larger perforations await the need of tectonic keratoplasty. But sometimes it's difficult to procure eye donations, and the smile-derived lenticule are a viable, inexpensive, and available tissue, which many authors have described to salvage the eyes during severe shortage of donor corneal tissue. So aim of this study was to report the outcomes of unconventional strategies and innovations for emergency management of large central and peripheral corneal perforation. This is a retrospective review of the records and management outcomes of 7 eyes of 7 patients. The patient presented with complicated corneal perforation and were managed on emergency basis using preserved allogenic scleral tissue or femtosecond smile-derived lenticule, which was cryopreserved at minus 80 degrees centigrade. So the results, we've included 7 patients. The mean size of corneal perforation was 3.5 mm. 5 perforations were central, whereas 2 were peripheral. The modality of surgery that we used was smile lenticular graft was used with glue or sutures in 3 eyes, along with scleral patch graft in 4 eyes. The globe integrity was preserved in all eyes at 2 months follow-up, and there was no incidence of graft displacement, aqueous leakage, additional stromal lysis, or immune rejection infection post-operatively any of the treated eyes. The BCVA improved in 3 eyes and was maintained in 4 eyes. So the causes of the perforation in our cases were sterile melt was present in 4 cases, infective keratitis was 2, and traumatic perforation was there in 1 of the patient. So this is the first case where we had corneal perforation following viral keratitis. This was the photograph when the patient presented with a central perforation, and the cornea was thin around it. And so we applied a smile lenticule graft along with fibrin glue, and AMT was applied over it. And after 2 weeks, we can appreciate the globe integrity was maintained. And this is another case also of viral keratitis with a perforation in the paracentral region with vascularization and adjacent corneal thinning. Here also we have applied the glued smile lenticule. And this is a patient with infective corneal melt with hypopyon, and surrounding tissue melt also was present. Here we have applied smile lenticule, which was sutured and along with amniotic membrane over it. And this was the photograph of the patient after 1 month. And this is another patient with fungal ulcer who presented with perforation, and the anterior chamber was very shallow on the day of presentation. And this here we have sutured a smile lenticule, and over that we had applied an amniotic membrane. This was the photograph after 2 weeks, and after 1 month we can see the there was uptake of the graft, and there was induction of mild vascularization, and the globe integrity was maintained. So in all the patients, the globe integrity was maintained, and various previous studies have described the use of smile lenticule in corneal perforation. Wu et al. In 2015 described 1 year follow-up of 6 patients which were managed with this, and there was no relapse of infection noticed, and 50% had improvement in BCVA. Similarly, Yang et al. Described in series of 22 patients where 54.5% were of immunological causes, and in those series the BCVA improved in 54.5% of the eyes and maintained in 40.9. So I would like to conclude saying that use of stromal lenticule from smile surgery may be considered as an alternative method for treatment of corneal ulcers before more extensive and definitive solution PK is performed. Our findings suggest that properly performed corneal smile lenticule transplantation using cryopreserved lenticules is safe and effective method. Thank you. These are my references.
The lenticule was inlay or onlay?
Lenticulus inlay, sir. Over that amniotic membrane was used.
So how you put inlay in that case? In the case?
Wherever the perforation was present, the adjacent edges were slightly debrided. The epithelium was also debrided over the rest of the edges, and where the maximum size of the corneal perforations were usually up to 5 millimeter. We can do this because the lenticule size is 6 millimeter that we've used, and in that first we put the lenticule followed by with a fibrin glue assisted attachment of the lenticule, and then amniotic membrane was put over it with the glue and sutured in the periphery.
No, what I am asking, see, removing only epithelium will not sustain the IOP. So you are dissecting like you are making some stromal pocket.
No, we
to
didn't
put
make a pocket. We just
sutured it.
sutured it there. Sutured it or put a glue over that.
Because
Yeah.
see, fibrin glue doesn't have that much strength to
Hold it.
hold the IOP like in that case. So if you are making a tunnel or you're suturing properly, like because interrupted suture again it will not work in this. You have to put continuous suture so that the fluid should not leak in that. If you're putting inlay like pocketing, dissecting pocket and then putting, then it's okay. But if you're putting onlay over, see epithelium is not like epithelium debride and then you put, then it is onlay only, it's not inlay. And even after that if you put amniotic membrane, then also it's not going to serve the purpose.
Because the
So how
corneas
it
were
was
very
like-
thin. Corneas were very thin to make the pockets. This was done when there was a time of COVID, and we didn't have any donor corneal tissues for managing all those perforations. So that time we rescued all these eyes with the help of smile lenticule.
So in viral keratitis, you have seen, what is the cause of melt in viral keratitis? What do you think?
The patient presented as such on the day first when the patients were presented with the perforations only. Maybe they were inadequately treated or there was recurrence of the infection that caused the further thinning of the cornea, and then it was perforated.
Like viral per se is causing stromal melt or any
No, it's because of immunological reaction that is happening, and the inflammatory mediators are for the causing the melt.
Yeah, that's not the infection which is causing the inflammatory mediator. So what you did for that?
For that, for viral cases, we had given topical steroids as well and antiviral therapy. But the other infective cases, we couldn't we couldn't give them topical steroid. The graft had opacified, but many studies they've suggested that the smile lenticule per se would remain clearer compared to other grafts.
That's the important thing is that if you put onlay over, then there should be leak actually.
Can we call it as a piggy bag or a sandwich approach?
No, when we are putting even for amniotic membrane also, when we put onlay over that, it will leak. So if you put dissect a pocket, see these are loose cornea, so easily you can dissect, and it's more than 3 millimeters. So your crescent can easily dissect, and then you can tuck it inside, and then you can put it over. So it will have a strength. So I don't know, like whether you have done Siddle test for these cases or to see whether leak is there or not.
In the day one, like the anterior chamber was well formed and IOP was well maintained.
Till the air bubble is there, it may be formed after that. Anyway, it's a good presentation.
Thank you, sir.
ठीक बेटा, thank you.